And so we're recording this session, personal hygiene and care of patient or clients. You're going to be going into a whole variety of care settings for both your taste days and also your placement. What we want to ask you to start off with is to think about the sort of fundamental skills that you are going to be required for patient care. So the next thing is I'm going to launch a poll and ask you to vote on how important to you are the fundamental skills for patients. I'm just going to wait a second, right? Is it more important than academic study? Is it as important or is it less important? We're doing quite well. Just go wait for a second. 73 of you voted. 73% have voted. Sorry. And you'll be seeing the results as it comes up. Okay, pretty much there. Well, I'm relieved to see that you think it's as important as academic study. Some people think it's more important. That's okay, that's fine. And, you know, that's acceptable. I'm glad, I'm desperately delighted that nobody thought it was less important than academic study, because to be able to give that care, to be able to ensure that patients also receive fundamental care, you do have to have the underpinning knowledge. Right, I'm going to close the poll, share the results with you, just in case you didn't see that, and then I'm going to hide that. I'm going to close the poll down. Can I just check that? Could somebody please let me know if they're still got the poll on view, or whether you're back to the PowerPoint, only because I made a mess of it the other day and had problems. You still see the poll. Okay, let me sort that out. It took me a minute or two to sort it out last time. Okay, some people are back to PowerPoint. Ooh, some people are still seeing poll. If I move the slide on and ask you the next question, can you see the next question? Because the question is, okay, are you too posh to wash? When you do some reading around this subject, and certainly over the past few years, and investigations into poor care across the nation, there's been this big thing over the past few years that student nurses, because they're studying a degree, consider themselves too posh to give personal care to patients. And you will see too posh to wash. And there is some there is a paper, a sort of I can't think of the word I was going to use, a sort of statement paper as to what needs to be done in nurse education to ensure that people aren't too posh to wash. I don't know whether you've heard of that before, or what you think by that term. If you want to whack some answers up, I'll share that with the group. So who feels they're too posh to wash then? Or not? Never too posh, thank you, Jessica. Fantastic. Okay, those of you that are feeding back on this one are saying no. I'm glad. Those of you who aren't, I hope you're thinking that you're not. Last year when we did this, one of the participant students was very incensed that the general public and stroke the nursing profession, who are now feel that students are too posh to wash, and did a big thing on Twitter through Punk for about a couple of hours. The discussion went on afterwards. But do look at this term. Have a look and see what the general public feeling. It has been stirred up immensely by the press. And you will find and when I talk about the press, I mean the red top newspapers, the Sunday Times and the Guardian and all that. Not so much in recent years, but you will see it coming up. So we move on to see what fundamental care actually means then. So personal hygiene. In your psychology elements of our course, we talk to you about what the fundamental role of the nurse is. And what we look at here is Maslow's hierarchy of needs. You will have visited this and you will visit this in more, but it is fundamental. It is essential care. And a lot of the nursing models that we use, the way in which we deliver care and the framework in which we work with for delivering care meets Maslow's hierarchy. And in actual fact, all aspects of Maslow's hierarchy are met with fundamental personal hygiene care. And we'll look at that as we go through. So, yes, Florence Nightingale said, it's as bad as administering a dose of slow poisoning by mouth. That's quite interesting. I was talking to the Cornell students yesterday about drugs administration. But what Florence Nightingale is saying is that if you're leaving people feeling uncared for and unattended in terms of personal hygiene, it's not a good thing. So what do we mean? There's a whole range of things here. It's about these aspects. Quite a few elements there, and you're going to have some practice in the ward when you come in for your skills days, and an opportunity to explore the ways in which these different particular elements of care. Now, we are aware that many of you have worked in care before and have actually given care, personal care to patients. What we need you to do as students is to start to look behind rationales, reasons, and the evidence and the research to support why we do and how we do it. Part of this course, we use the Marsden Manual as the Bible. It is used in clinical practice. You can access it online, and you will find it in care practice settings. So, what is the purpose? Why is it important to assess the patient, and what are the benefits to the patient? I want you to have a little think, and we'll just focus on those now. There's quite a lot here on this, isn't it? And I think the thing, not only is it feeling clean and fresh, it's those other things. Sorry if I'm deafening you, my earphones are slipped. There's all sorts of bits of things around that. There's comfort, feeling comfortable. It builds people's self-esteem. It has those psychological factors. And when you're engaging personal hygiene, you're engaging in a lot of other activities as well. You are assessing the patient. You are communicating with the patient. And you are actually beginning to get a better picture of them as well, what you see, as well as your communication with them at the same time. The social norm thing is interesting because you need to think about, when do people want to have personal hygiene delivered? The majority of our cultural way is that when you get up in the morning, you have some kind of freshen and refresh. Most people expect to have that first thing in the day, and therefore when you go into the clinical environment and the routines that you will see, it's usually the earlier part of the day. You will also go into clinical areas and people will give patients a choice when they want to have. And still you will find the majority will want it at the beginning of the day. It's about a social norm. It's about presenting, it's about the way in which we expect to present ourselves as clean, fresh looking, and also how people will feel when they're unwell and their reduced ability to maintain that. That gives you the kind of security as well. Now, the cultural and religious beliefs and norms also come into it. There are certain cultural beliefs about washing and cleansing, and we need to take those into account. And also certain rituals around the actual washing and cleaning. And therefore, you need to be aware of what those particular religious and cultural beliefs are and be able to meet them. I'm going to go on another slide or so, and then we'll stop and look at what you have to say. I've talked about assessment. Part of the assessment when you're giving care is to, okay, we're looking at the routines, but it's also, and those beliefs, and also their preferences, but also you're looking at their limitations and abilities to be able to give the care that they would want to have. Some people, when they're feeling so unwell, don't feel like bothering. How many of you, when you've had flu or have been really unwell, do not really actually feel like getting up and having that shower that you normally have, or the bath, and you may postpone it to later in the day, or you may even not have it that day? So you have to accept that some people feel so much like that that they don't want to have that care. And you have to be respectful of that choice, but you may want to consider persuading them to maybe just have a limited freshen up, just to help a little bit. And we'll talk about some of that in a second. Okay, so what are the benefits? Ideally, it hopefully reduces anxiety and promotes relaxation. You're also, as I said, structuring their day. Key thing as well is their skin integrity, is in ensuring that skin that is clean, or if they have issues around continence, that you're promoting that cleanness and skin integrity. You're able to assess the patient, as I've already said. You're able to assess their ability to move, their ability to self-care, and what their limitations are. The interaction between you also is about developing what we call that therapeutic relationship, getting to know them more as a person, more on how their illness is affecting their personal life and their ability to continue, maintain what they see as what they want to have as a normality within their life. And you can only do that through communication and understanding and assessment. Now, it's interesting, the care through physical contact. And the other thing around that is, obviously, and we'll talk about it again some more, but I'm going to talk about this now, is you have to gauge about how people feel about their privacy and their dignity, and also what they feel is acceptable for somebody else to do, in terms of their modesty, in terms of cleaning areas that could potentially lead to great embarrassment. So whilst we're giving care through physical contact and demonstrating that we can provide care and it improves their well-being through us physically washing them, touching them, and that you think about the way in which to do it in a professional way, and the way in which to do it is to reduce their modesty, to keep their modesty and their self-values intact. It says it gives nurse satisfaction, and you will find papers written about this, but talking to nurses, it's worthwhile when you're in the clinical environment asking people about, what does, having given personal care and standing back and seeing somebody looking physically better, and you may have improved their well-being, what that actually does for you as a nurse, taking pride in the care that you give, because the care that you give is reflected by what people will see when they look at the person who's received care. So I'm going to pause now and see if you've got some questions that you might want to ask about the things that I've talked about at the moment. Okay, there's a few bits and pieces coming through. Let me see what you're talking about. Oops, yeah, Rebecca's had a little Google about too posh to wash and found there's a hell of a lot coming up. And you're not impressed. Thank you, Rebecca. So absolutely, please do have a look and take into account why people perceive things that way. And what I'm challenging you all to do is crash those perceptions, change people's opinions of student nurses. You're the nursing of the future. Please do not underestimate the effect and impact you can have on the public and the nursing profession's perception. Important to get involved with fundamental skills. Okay, so somebody's actually, and Rebecca's again has said it's satisfying. You know, people who haven't had time to put their makeup on a few days or do their hair properly makes a hell of a difference. If people are uncomfortable and refuse to wash, thank you, Dominic, that's really important to say that. At the end of the day, there are other options. You can maybe say, well, do you want me to just help you with cleaning your teeth, or do you want me to just, you know, face and hands, and then saying, how are you feeling about that? Do you want me to go some further? If you can't persuade people to do it, there is a line when people have deteriorating skin and deteriorating physical conditions. Maybe if there's a continence issue and they won't, that you're going to have to go back and try again and see if you can persuade them and cajole people into feeling more comfortable. But if they say no, they're saying no, as long as you document that somebody has declined to receive personal care. That's really important. The other thing you could offer, they may feel happier if one of their relatives or carers give that personal care, and this is often maybe with children as well, that they don't like the idea of a stranger nurse come, you know, helping them do these things. So maybe their parents, people's carers can also do that. Don't forget that carers also feel that maybe they want to do this, or relatives, and it's important to involve them in that process. And if they want to do this because they feel that this is important to them, to enable them to be able to do that with your help, and not to actually exclude them from something that they may have been doing for their relative. I think that's really important. Cultural requirements. What cultural requirements are there? You need to be aware and need to look things up and in relation to it. And also you'll find that the organisations that you go and work in will also have guidelines. But essentially that you come across a whole range of people, and sometimes it's to do with religious times, in times of which people wash. But certainly one of the well-known things that obviously you don't know, but things like people who are for Islam. There's this cultural thing about obviously opposite sexes, about giving care that way, and also they require to wash under running water. So if somebody's strung up with a broken leg and require to wash with running water, how are you going to facilitate that? You may have to get a bowl of water and a jug and pour the running water, as it were, over them. So there's that. There are other kind of things around also about washing before eating. Now, it's actually quite good to wash hands, you know, patients to be able to wash their hands before they eat, but there are also religious kind of things around that too. They will tell you themselves as well if they have those requirements. But you can, there are references around that. Again, look in the Marsden Manual, they'll tell you about general things. But obviously there are other more fringe type things that religious or cultural that people will have. And certainly if they do, they generally will actually be quite clear about what they want to tell me. Okay. Yeah, Wayne's identified. I talked to the Cornwall students yesterday about, you know, starting that communication with patients and saying, well, I'm a student and well, I don't know anything about you, and how you can, you know, start conversations. What I particularly said was that students at this stage that you're at have the perfect opportunity to, one, rehearse and develop their communication skills, but also to talk to patients about their lives, how their illness affects their lives, what it means to them, both in the hospital environment but also in the home environment. It will broaden your understanding of particular things that affect particular conditions. Nico's asking if, as she's not had any experience, will we teach you how to do this? Yes. We will teach you how to wash various bits of the body and the right way to approach that when we do skills with you. Yes. Is there enough time on board to set aside to give good personal hygiene? And Jessica's saying in her experience in care homes it wasn't. There's a good thing for you there, a good challenge for you. Have a look and see. I would like to say yes. And decisions about how the work is divided up between the teams, and you'll be part of that decision, be part of that process, and that's fine. Right, Katie's asked for cultural variations. I've talked about Islam. Yes, thanks, Donna. Donna said that when she feels unwell, freshening up makes her feel totally different. And in my experience, if even the person who really doesn't want it, if you say, shall I just do your face and hands? It's enough to make them think, actually, I feel better. If people are very hot, they've got high temperatures, they're going to be sweating. And even just mopping somebody's brow, I know that sounds a bit sort of, I don't know, it actually makes a difference. And there are little techniques you'll learn. I worked in respiratory care, so breathless people with high temperatures, they get very hot, and they get, feeling really uncomfortable, but they have breathing difficulties, and you have to limit how much you move them, otherwise you'll make their breathing worse. And things like just putting a flannel that's got a bit of cold water or around the back of the neck just for a little while actually makes people feel refreshed. Yeah, what do you do if people don't want to be? So if we're talking about the private areas, the perineal area, if people don't want you to do that, hopefully they could actually do a little bit themselves, although some people will not have that ability, that they can do bits of themselves, and it promotes movement in the bed as well, but also it promotes the self, that they can do things for themselves. So you're not taking it away completely, saying, now you're going to give you a bed bath. Many of you might have seen Carry On film, where they say, right, we're going to do this bed bath now, and completely, treat the patient almost as if they're not there while they're doing it. But actually, that patient could have done 90% themselves, which keeps that sort of reduced embarrassment and also promotes the individuality. Rachel said there's nothing like a thank you from a patient and a family member when you make a small gesture, such as helping them with their makeup and giving a shave. Totally agree with you. Some men won't shave for a day or two, and those of you that are blokes will know that it doesn't take long before you're feeling a bit rough and raggedy, even if you are trying to get that kind of effect. You still feel rough and raggedy, and if you're unwell as well, also, it's, if people's dexterity, if they're old and their dexterity is affected, then it's difficult to shave, and it's going to be one of those skills that you're going to have a go at. And you're right, in my own personal experience, somebody having a shave actually feels a hell of a lot better. Yeah, do ask people how they like to be washed. Yeah, somebody's talking about taking time and giving that. It's about addressing imbalance, making feel lengths. Somebody's asked, would female students only wash female patients and the opposite for males? And the answer is no. As you know, there's more female nurses than there are male. With the male students, it's more tricky. You will find, as you will be caring for female patients, that you will have to ask them if they mind if you do this. You will have to ask them if they mind you helping them to the toilet, the whole kind of thing, and they might say they prefer to have a female nurse, and it is vice versa. Generally speaking, patients think, I'm in hospital, so I have to, if it's male or females, but that doesn't mean that you don't ask their permission. Is it okay if I do this for you? The same way you would introduce yourself and gain consent for anything. We'll come back to what you're saying in a minute. I'm going to move on. Okay, so some of these things I've kind of talked about. If you don't assess people and you don't give good care, then people lose their independence, and that means losing self-esteem, and that's really important to notice that and to think about that when you're engaging with patients. There is an increase in pressure sore risk because skin integrity, if somebody is unable to move, and also keeping the skin clean is known to promote skin integrity. And again, infection rate, because again, clean skin, growing bugs, heat in rooms and all those kind of things. There's always, of course, the infestations. You will meet people who have got things like lice and etc., and therefore they may well need some additional treatment. And we talked about distress. Could it delay a discharge home? interesting one. If you can't restore people's independence and self-esteem through assisting them with their care or giving them that care, to promote them to move towards self-care, or assessing them for care needs at home, i.e. will they need somebody to go in their home to give that personal care, then you are delaying discharge, which leads to increasing costs for caring for patients. So, just in case you hadn't noticed, and we've been talking to you about cross-infection work from the word go, think about what you're doing, and we'll talk to you about this when we bring you into the ward to do these skills. Don't shake linen. You're wafting all sorts of dead skin cells, etc., around, making sure it goes into the right linen skip, and don't share washing equipment with people like bowls or flannels and all those kind of things, because there's a cross-contamination. Thinking about your personal protection, and certainly don't have soiled linen on your uniform, and therefore if you know that the linen is going to be soiled through your assessment, that you're going to wear aprons at least, and possibly gloves. Do you know, we've covered some of these already, and I'm going to go on a little bit more just to cover, so a recap on some of the things that I've said. So I've talked about independence, we've talked about consent. Whilst you're giving personal care, you're doing those risk assessments about manual handling, you're looking at, is there, what are our infection control measures that we're doing, and also pressure ulcer risk assessment. Also, no, there's another one there. I've talked about privacy and dignity. Think about ensuring that curtains are closed, and think about going in behind curtains, or people going in behind curtains if they're drawn. I'm hoping, go out on your taster day, those of you going into ward areas, look and see what people are doing when curtains are closed. Are they just opening them and going in saying, excuse me, or are they actually standing outside the curtains and say, is it okay to come in first? Because that is the way to do it. Thinking about keeping patients warm, thinking about the water temperature, and making sure that you may have to change the water throughout the procedure. Think about how you're positioning them. If people are going to be in pain because you're going to move them around, you may consider giving them pain relief before starting the procedure, especially if they've had operations, and you'll get the best there to be able to give good care, but also help them start to regain their independence and mobility, and etc. And we're talking about making sure that overwashing, you're not drying the skin, and thinking about what are you using soap, are you using special creams, etc. Is anybody else saying anything else? Okay, I'll review chat again in a minute because I spent quite a little bit of time a minute ago, but please start asking the questions. That's absolutely fine. All telling us things, that's great. So what are we looking at? We're looking at the condition of the skin when we're assessing them. You're looking at the color of the skin. Is it sort of color, same sort of color all over, or are there areas that are discolored? Is the skin texture as perhaps yours is, or is it papery, or is it squidgy when you touch it, edematous? Please be aware of intravenous infusions, drains, cannulas, all those kind of things, and make sure that you're not going to do something to dislodge or damage them. Questions about flannels, disposable or wipes. Some people will want to use flannels sometimes, but it minimises infection risks, and also sometimes better to use disposable wipes. Should we use soap or creams? Again, it's patient's preference. A lot of people don't like to use soap on their face because it's drying, and may just want water. A lot of women these days use special cleansing wipes and may prefer that. You need to be careful with the skin folds and crevices. You need to ensure that they are well cleaned, because skin sweatiness or soreness can develop quite easy. Thinking about drying, you need to pat dry. Rubbing can cause abrasions, especially if the skin's frail, and you need to minimize exposure of the person, one, because it makes them cold, but also their privacy and dignity. Let's talk about nails. Well, my colleague Kevin always likes to put in horrible looking photographs, but it's important to be aware of. People with children or learning disabilities don't necessarily pay attention to their nails. If people are visually impaired, then they can't see their nail care, and also if they're older and they can't actually reach their toenails particularly well, then there may be issues around growing. You have to be careful with people with diabetes peripheral neuropathy, and the answer is that they have reduced circulation, and therefore easily the nail beds can not have a good supply of blood and can actually start to be damaged, and it's easy for damage to take place. With diabetics with neuropathy, peripheral neuropathy, they lose sensation in their extremities, and it's very easy for them to stub their toes, for example, and not know they've actually done that. So thinking about using nail clippers and emery boards, think very, very carefully, and you need to see what they do on the ward areas, because some ward areas will call in chiropodist, podiatrist, or to give nail care rather than attempt nail care when things look a bit dodgy like these. But you need to assess the nails. Here we've got what looks to be like an infection, for example, a fungal infection, or it could be as a result of neuropathy. You can see the discoloration in the toes, and here as well you can see this discoloration. This little black area means that there's no blood supply getting in. Always report and document your findings. Now, I knew this was going to come up. Somebody's raised that we've been told not to touch nails. You need to check what the policy guidelines are within the clinical area. You can clean the nails and all those kind of things, but sometimes nails, I mean these for example, I would be very cautious of touching these because you can cause more damage. So again, it's dependent on each person's individual requirements, and seek guidance from your mentors on what you can and can't do. Hair care. It's very true washing hair in hospital is given a low priority. However, it does promote positive body image and feeling better, and we've already touched on that. And it is choice and preference. Again, again, this is a way to involve family members. Can people physically get out of the bed area and get to an area where they can have their hair washed? You can actually use dry shampoo. And the products on the market these days aren't bad at all. However, that might be difficult. At the end of the day, you can do some minimal kind of cleansing, but dry shampoo is quite good. And in the clinical areas, you may find that certain gadgets and things that they use. There's these sort of plastic hats that have got shampoo impregnated. You put the hat on the person and rub it all, and it actually cleans them. It's a dry shampoo kind of effect. Obviously, yeah, Kevin's mentioned head lice here. Is also important. Sometimes you have to wait for people to get a little bit better before you can do their hair, but please consider that, and have the opportunity to offer. There are hairdressers, some of the placements, certainly if you go into care homes on placement, you'll find that there are services there where hairdressers come in, but some other areas also provide that service. Obviously, or allow hairdressers to come and tout their business and give people the opportunity. And quite rightly so. Don't forget, beards and moustaches also need that extra little bit of cleaning as well. So we've talked about shaving, and what should we use? It's the patient choice. You can use the individual's own equipment, make sure it's clean and it's safe to use. Sometimes old gentlemen will come in and have the most archaic looking razors that they're happy to use. Obviously don't loan them out to some patients will loan things out to each other as well. And don't forget also that some women do choose to shave as well, because they develop whiskers, which happens post-menopause. Okay, so yeah. So what type of patients may need mouth care and why? I'm just going to quickly look at the questions here. Self-shampoo, yes. So yeah, so Rachel's seen the self-shampooing caps, and also hairdressers. Great, Rachel, that's really good. And yeah, feel more like themselves by helping them to do their hair. Do you know what? Sometimes running a comb through somebody's hair that's sticking out all over the place makes them feel so much better. It's the little things that make the difference and make you feel good about what you're doing. So, oops, I've gone back a bit. Where am I? Right, we're talking about some mouth care. Great picture of some gnashers there. If somebody's unconscious, they're not going to be in a position to be able to give mouth care. Again, facial injuries, people who've had strokes may not be able to clean their teeth in the way in which they have done before, and therefore, and may have difficulty because of facial paralysis in being able to clean their mouths. If people aren't eating or drinking, the saliva in their mouth is going to dry. And cause skin deterioration within the mouth. Certainly if people aren't eating very much also. Your eating stimulates saliva, which keeps that mouth moist. If somebody's been artificially fed, so they're not eating through their mouth and they might have a tube through their nose to be fed by, or even a tube into their stomach to be fed by, their mouth is still going to become dry. Immunosuppressed means that their immune system is being altered, and this is usually due to people having therapy for cancer, which also suppresses their immune system, or transplants where you have to take drugs to suppress your immune system. Post-operative, if people have had operations, they may not be able to eat or drink for a certain period of time. Oxygen therapy dries the mucosa, and therefore good mouth care is important there. Certain medications cause dry mouths. If people are malnourished, things like vitamins help to improve the skin integrity within inside the mouth. Again, if people have learning disabilities, mental health issues, they may have forgotten to clean their teeth or don't see it as important, etc. And so the list goes on. Okay, yeah. Somebody's included dying people. Very true. It is really important, and to me, it's a sign of poor care if you have neglected somebody's mouth. And there are times when people need frequent mouth care throughout the day, not just the bit first thing in the morning. You know, what's it like when you go to bed with, or if you've had food and you've got food still stuck around your mouth and cakes? You know, it's not nice. Talk about self-esteem. Not only that, skin deterioration, and especially with illnesses that affect the breathing, because if you mouth breathe, you're going to dry your secretions out. You've all done that. You've all had colds, blocked up noses, and your mouth becomes very dry. Think of that 10, 20, 100 times, you know, and seeing bits of skin and secretions sticking and drying in people's mouths and their lips and all that. It's only a visual display of poor nursing care. I can't influence you enough. I want to feel that some of you are saying things like, you know, it's worth it. It's worth giving mouth care. It makes people feel so much better. Some of you are saying that, and I don't disagree with you at all. There are certain, we go on to talk about tools and equipment in a second, so a couple of you have come up and talked about some of the things you can use. So there are several oral assessment tools to assess people's mouth, but you're looking at the tongue, thinking about teeth, dentures, saliva, the mucous membranes, yeah, the lips I've already said, also their mental state to see whether they you know, have the medical ability to think about what they're doing, and also their nutritional intake, and if they've got pain inside their mouth, how difficult that is, because certainly if somebody's got oral thrush, for example, which if you're immunosuppressed, it's high on the list, then it's too painful to put toothbrushes in the mouth. So think about your scoring with the risk assessment, think about what you need to document, follow the plan that you need to follow for that, and look at how well they're doing. Kevin's just highlighted a particular example here, but you'll see what is used in your clinical environment and use that. So what do we need to do? Again, you're coming into contact body fluids, so it is a glove and apron job. Toothbrush and toothpaste may be useful. People might use dental floss. You'll find antibacterial mouthwashes available in the clinical environment. You will also find foam sponges that you can dip in the liquid and move around the mouth gently. Lemon and glycerine swabs, sometimes they're in, sometimes they're out. It does make the mouth feel dry, but the recent research shows that they're in again, and we'll do all these things with you. Somebody mentioned pineapple. Pineapple research has been shown that pineapple is good for minimizing infection, and also it is high on the refreshing feel. And so, yeah. Pineapple. Sucking ice is a good one. Obviously, you have to assess the size of the ice cube that you're going to ask somebody to suck, but by sucking an ice cube, really good for people who aren't allowed to drink or eat, but they can, sucking an ice cube will moisten the inside of the mouth. Sodium bicarbonate or hydrogen peroxide have been in, but you need to be guided. So one of the things you can do, maybe not on your taste today, but please do if it's relevant. But when you go into clinical practice, look at what the local guidelines are for mouth care. One of the first things that you can do. Yeah, you might use small soft toothbrushes and all that kind of thing. Somebody's asked if you can offer lip balm if lips are dry. That's okay, and some people might bring their own. You have to be careful because they have most of them have liquid petroleum in that, and if somebody's receiving oxygen therapy, then it's a combustible agent, and you will see if you read into it. Probably some nice photographs of people with facial lip burns and scalding on the lips through wearing lip balms and oxygen. So always be guided. Let's talk about false teeth. Some people like to clean their teeth more than once a day. You can use toothbrushes or denture cleaner. Some people may not have the dexterity because of their illness to be able to do this, and you may well have to do this, and obviously you need to make sure you rinse it. The other thing is that people often do is soak their teeth to reduce fungal infection. The other thing is people will do is take their teeth out and stick them in lockers or wrap them up in tissues or stick them in various things. Always make sure that you're checking the sheets when you go to put them in a linen bag, that you haven't got someone's dentures in, because once they've gone to the linen room, it's nigh on impossible to identify who those people's teeth are. And obviously you would use gloves when cleaning people's teeth. Right. I've kind of talked a little bit about this already, what else you can do. You could also go on to do their vital signs. We've talked about communication. You may have opportunities for health promotion. Certainly we've talked about social interaction, assessing their skin, their hydration, nutritional status and psychological status, and their physical state. There's a whole range of assessments that can take place, and I've kind of touched on the majority of those, and that's a good opportunity. Right, I'm keeping up with your comments and questions. But we've almost come to an end point, which is fantastic because I'm almost keeping myself to time. If anyone else wants to say any more comments or ask anything, please type it in. But essentially, we've identified it as a fundamental role and it's essential. It's about treating that person as an individual and respecting them and doing something very positive that can make people feel better. One of the key things of nursing that you can do to improve somebody's well-being, even if it's only for an hour or two, is this. You've got to think about privacy and dignity. You may need to think about special requirements for on an individual basis, and those can be or will be documented, like religious preferences, etc. Obviously, you've got to assess what you're going to be doing, you plan how you're going to do it, and then you do it, and then you evaluate, you keep your records, you think about infection control, and obviously all the care that you give is evidence-based. The Marsden Manual will have details on giving personal hygiene. We will pick up on those and do this with you when you come into the skills ward, but also you'll have local guidelines for such things as mouth care. and the risk assessments. We'll be doing risk assessments again with you when you come into the ward for your practice sessions, but you need to also look at that for things like some of you have already done manual handling, and then there's things like falls, skin condition, pressure risk assessments, a whole range. Here's some of your references. So this will be posted for you as well as the recording as well of this. So for you to come back and revisit. I'm going to give you just a minute or so if you want to ask any more questions on hygiene. Otherwise, we shall pause in a moment, give you a comfort break and move on to the next one. Anybody got anything else they want to ask or comment on? Right. It's 9:47, so 9:50, just after 9:50, I'm going to start the next one. So go and grab yourself your coffee or whip out to the toilet or whatever. And I'm going to prepare the next one. Right, folks, we're back, and I'm just going to check. I've just got to fiddle around with a few things again for myself. Suzanne's already posed a question. Suzanne, thank you very much, because we're going to talk about this, I have no doubt. She's talking about the quality of hospital food, and why it's an issue. It will become apparent as we go through. So I'm going to start the nutrition, and I'm going to again pause as we go through for you to for me to review some of the things you're saying or you're asking, and we've got about 50 minutes to work through this one, and then I shall confirm with you what time I will start the next one, which I'm just looking at now. I'm going to have to double check that with you. That's okay. I'll double check that before we finish. I thought I had it written down, but if I have, I've moved the bit of paper. I just want to get cracking. So we're looking at nutrition here. Oh, hello. Okay. So what we're going to be looking at is thinking about healthy diets, thinking about the dietary needs, how we identify people at risk of malnutrition, and looking at ways of improving people's nutritional status. So yes, why is good nutrition important? Since we started looking at this in this module, there's been an awful lot been going on, and we can't move away from the national concerns that we have around the state of the nation and obesity and the role sugar has to play in that. But what we want to look at, and you'll be looking at this again as well in other modules, is what our roles are in terms of this. Yep, you are what you eat, or not eat, as the case may be. So key things to recap for you is thinking about needing that energy and growth and repair and resistance to infection and the body functions. The key things. The other thing to say, again, obviously if people are unwell, then they're going to have additional requirements for regeneration of their systems and their body to become well again. So some key bits. Whoops, sorry, I'm not getting, sorry about that. Got carried away there. I thought there was another point there. Oh, and another point. Let's get carried away. Right. So we have food groups, our carbs, the vitamins, and the minerals, and then the meats, which also give us vitamins, minerals, and also fats and protein. Again, when you do biology, you're going to be looking at these in more detail, so I'm not going to dwell too much on them. But here we go. Good old fatty sugar foods. And of course, we need to think about water as well. There is endless exploration into nutrition and what's nutritious and what's not, as well as endless diets and better ways of eating that will come and go throughout our lives. Some of you may well have seen the Eat Well plate and looking at the divisions of what proportions you should eat certain things in. And again, I'm sure you'll be looking at this in other modules. There are some updates on this. I was trying to look at this today, but there are various surveys and thinking about the 5 a day portions of food, and now what's being said is that more than 5 a day is what's required. And then where did 5 a day come from? And there's this also being raised in the press that it was all down to sticking a finger in the air and thinking what would be good, and it was also related to the orange growers in California who would be making more money if they promoted a 5 a day cultural concept. Don't know if anybody's heard that one. Thinking about fiber. Salt is the devil at the moment, and certainly salt increases peripheral vascular resistance, and therefore is what's called a silent killer because it increases blood pressure and is at risk. Saturated fat, what's good and not? Well, in 2005 they said reduction, but now there's the thoughts that actually saturated fat is actually better for you than modified fats, and only in recent months they've talked about things like butter and lard being better for you than oils, and so you will see these fluctuations in what's current and what's a good idea. Added sugar intake, there's a whole thing going on now about reducing sugar and the hidden sugars in foods, and challenging supermarkets to label foods, and also vendors such as fast foods and McDonald's, etc., 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 etc. So what you see recommended there and what's recommended now and what might be recommended next week is very difficult to keep up with. Right, thank you very much. You are quite correct. 2 minutes silence at 11 o'clock. Thank you, Louis. I did think about this morning at 7 o'clock on the train, but you've reminded me we've got a couple of minutes to go for our silence at 11, although I should be finished by then. So we should finish before 11, but just in case, thank you for reminding me. So, nutrition through the lifespan. These things we do now, I've talked about things that will change. Healthy eating guidelines, but changes might occur when a patient's ill. I've already said that. People who grow older have different energy requirements, and it decreases with age. The basal metabolic rate changes, and therefore need to think about the proteins, vitamins and minerals required for older people. And again, vitamin D. Best way of getting vitamin D is sunbathing, as you may again see as being very much in the press at the moment. And older people, the best way to get your vitamin D whilst you can have supplements is actually to get out in the sun, which is an interesting one because sunshine's bad for us in terms of skin cancer, and also elder people's skins haven't got that protection to UV light that young people's do. So it's, as always, everything in moderation. Well, I've already identified a few things about what's current issues around nutrition. Does anybody want to add to the things that I've talked about? Giving you a minute or two. Or ask any general questions while I have a slip of coffee. Yeah, energy drinks. Dominic, you're right about the danger in energy drinks in terms of people not understanding how it can actually affect some of the other organs, but also the high sugar content in energy drinks, and also Lucozade. Lucosade's an interesting thing because it's supposed to be improves your well-being, but actually it's very gassy, and sometimes drinking all that gas causes indigestion and bloating. So how good is Lucozade? Do UV lamps also provide vitamin D? Good question. Somebody want to Google that? Because I think the answer is no. But I might be wrong. Obesity, lazy shopping and cooking. Yes, fast foods and convenient foods are better than cooking nutritious. Food intakes. And also somebody's ability to cook. If people have got decreased ability or declining health, then cooking in their kitchen actually can be impeded by their health, and therefore it's easier for them to do a cup of soup or a pot noodle than to cook themselves something. And this is why these private companies that deliver meals to people's homes jump on that kind of, we can provide a nutritional meal in your home kind of thing as well. Yes, Jennifer, conflicting advice always makes it a challenge. Is it more expensive to have wholesome meals and ready meals? Well, you'll see lots of chefs on television. I think Jamie Oliver at the moment is doing a thing and also Hugh Fearnley-Whittingstall are doing things on how you can make fantastic food out of leftovers or whatever, but also you can do things very economically. Aha, binge keeping culture, doubling up on the late night binge eating. Binge drinking culture is an interesting one, especially weekend binging. People sort of, people in their 50s are now having more alcohol associated problems because they are, drinking at weekends, and they say give your liver a rest, but actually not drinking in the weekdays and binging at the weekends has been known to be actually just as damaging. The other thing, it's cheaper to drink at home, and therefore we don't really know the state of the alcoholic intake of people and all that kind of things. All sorts of things. Yeah, somebody's asked if patients want an alcoholic beverage, are they allowed? You have to check, because some of the medications that people take are potentiated or interfered with by alcohol. So if they're potentiated, warfarin is a good one, which is an anticoagulant, stops blood from clotting. Also, alcohol affects the way in which blood clots, and therefore it can also increase the effect of warfarin, and so alcohol is advised, not advised. So you have to check, and it is always about moderation. Many drugs may be affected by alcohol, so you have to do an assessment essentially, and then advise them or provide their drink as appropriate. Yeah, food advertising is an interesting thing. The whole thing around health promotion, you'll be doing this when you do health promotion in year 2, and you look at it in depth, things about advertising and judgmental attitudes to overweight people, and the whole kind of market. Yes, somebody's looked at Google for me, thank you. Yes, UV lamps do not give vitamin D, and I didn't think they did, but oh yes, seasonal affective disorders. Yes, sunlight improves you getting depressed in the winter, and then sun lamps are quite good to have in your home to give you that kind of light that would perk up your mood. Yeah, sugar is a huge issue, and the whole thing. Oh yeah, the cancer risk with processed meat. Very much recently, in the last week or so, it's been highlighted. And now we have a vitamin D can be boosted by UV light. There we go, contradictory advice. And it's really difficult, isn't it? Yeah, Louise, you're right. Red wine reduces the risk of heart attacks. Yeah, red wine does. But what it doesn't say is if drinking in small amounts and moderation, as always. Loads of misinformation, loads of things to process, but it gives us an opportunity for debate and discussion. Let's have a look at what we mean by malnutrition. Oops, sorry. Running away with it there. Apologise for that. Okay, malnutrition is about undernutrition, which is deficiency of the nutrients required. Overnutrition is excess of nutrients, such as obesity. So somebody who's underweight and overweight can be classed as malnourished. Interesting point there. Florence Nightingale said that. Very interesting. There is more up-to-date research on this. I was trying to find some bits and pieces this morning. Why were people in hospitals and nursing homes clinically malnourished? What are we not doing, or what are we doing wrong? Yeah, Rebecca's talking about assessment tools, and which we're going to go on to. They are a guide, but they don't always cover all the. She's talking about somebody who was had a BMI of 83 and scored 0 on a must. So these things don't always manage. But let's have a look. What happens about malnutrition? I think I've talked about reduced ability to eat due to ill health. or not able to eat, not able to have the dexterity to feed, or that actually eating causes tiredness and exhaustion. Any chronic medical condition that would affect intake, and most chronic medical conditions do affect the way in which people eat or are able to eat. Obviously, people with reduced physical and mental capacity, we've highlighted dementia. People forget to eat when they eat. Again, people with severe learning difficulties won't know whether they've eaten or not, and when they've eaten. And people even, in these conditions, they might have just finished a meal, but they didn't know they had. So it's quite or that they don't eat because they think they have. Really, and there's also the social issues around malnutrition, about people not being able to afford to buy food or to eat well. And we're talking about people now that increasingly can't afford to eat, are relying on food banks and all those kind of things as well. If there's reduced absorption capacity, so that's your gut can't absorb particular nutrients and minerals, then that's going to cause malnutrition as well. Again, some drugs will affect nutrient interactions. So what happens? Muscle weakness, potential risk of chest infections, and problems with circulation and mobility. Very much so about delayed wound healing and pressure sores and reduced skin integrity, which is of concern to the nurse in terms of getting people well enough to get out of hospital. Because if you have decreased nutritional status, then you're at risk to infections, and by having somebody in a hospital environment, you're increasing their risk of infections. And then again, it impairs your cognitive abilities, and also can cause apathy and depression. So let's have a look at nutritional assessments. There's a whole load of nutritional assessments available and screening to detect significant risks so that you can draw up. As I've said earlier, and you'll find with all the assessment tools that you use, they aren't comprehensive, they aren't definitive, and sometimes there are other things that you have to take into consideration. But as a rule of thumb, they're a start point for you to work on. Oops, review chat. Let's see, I know some of you have been putting some questions up before we talk about NICE guidelines. Rebecca's saying that her local gym runs overweight classes for young people with learning disabilities, and talking about how they can improve their health, which is really good. Ooh. Some of you are talking about hospitals. I'm going to come to that point in a minute. Yeah, depression. If people are depressed, motivation and self-care and not eating. Some diseases of the gastrointestinal tract will affect eating, and things like celiac disease, as Jennifer talks about, or Crohn's disease. There are certain foods that antagonize it, which means, and also if you've got inflammation and disturbances within the gut, you're not absorbing properly, so it can actually cause problems. Yeah, Wayne's highlighted that by creating a universal meal system, we don't necessarily meet all the needs of the individuals. Totally right. But if we didn't do that at all, where do we go from? So it's the same with all tools and plans. They need to be tailored to the individual, and they're a start point as a guide. So we are looking at NICE guidelines, which is important. So NICE guidelines, National Institute of Health and Clinical Excellence, we should identify when people should be screened. They reckon that 13 billion in 2007 was spent or malnutrition-related illnesses, which is huge. They reckon that everybody should be screened on admission to hospital or if they go into an outpatient appointment, when people go into care homes, GP registration, or if there's a clinical concern. Because we hadn't been screening people before NICE guidelines, this is why people being malnourished coming into hospital or being malnourished whilst in hospital, which is a point I'll go on to. At least by having a baseline screening, you've got something to go on. And the screening identifies if people are at risk. We've already talked about body mass index. What it looks at their weight, their height, and deciding what the scores are. So the BMI is a tool that's used. Now, again, there are questioning whether BMI is the appropriate tool to use for screening. NICE guidelines still say use a BMI, but you will find some other tools, and it will be useful for you to have a look and see what other tools you would find. And what would be useful to do is for you to calculate your own BMI. We'll be doing that with you in the ward as well. So this is a typical BMI chart, so you can have a look. You'll find them. You can Google it and find them. So let's look at some of these tools. There are 73 different tools. There are probably more than that since we looked at this earlier in the year. But as one of you has already identified, the MUST tool, malnutrition screening tool, is the one that is currently the thing to use. So it looks height, weight, so we get a BMI. It looks if anybody has any unplanned weight loss, and looks at any illness or disease, and then you add the scores up, and then you can develop a care plan. But as one of you has already pointed out, the BMI was high. I'd be interested to see what the other ratings were on that, and whether that's still effective. So you're looking at more than one element to formulate your plan, and here is a common one. You'll see it in all clinical environments to look, and it's giving a little bit guidelines and talking about who's at risk. So you have some risks here, but you also have an addition here of obesity, which brings me back to the person that identified somebody who's extremely overweight, but their BMI scored 0, which is that's the reason why. But it's interesting to see what other things might have affected that score. So what do we do? Why are people being malnourished in hospitals? Why would you have read about this in the news and newspapers and also healthcare journals? Part of it is that we weren't screening people or taking any notice of the bog standard patient, whereas NICE saying if you screen everybody, then at least you screen them, and if they come up as they don't need anything, then they've come up and they don't need anything. So you need to think about choosing high protein energy meals for individuals, and those that need assistance get assistance. It's also about making things looking appetizing, and again there's a lot been going on about the state of food in hospitals and how poor it is. So last year our local hospital in Cornwall has 58p per person per day allocated into their budget to create meals. That's per day, not meals. 58p per person per day. There are guidelines around for them, for the people that make and the menus and also the food, to look at how to be as nutritional as possible. But a lot of you will have watched James Martin's pioneering to improve hospital food, and there was a series on television where he's gone into hospitals, looked at how they're catering and look at how they can improve for the same cost the food that they're delivering to improve the nutrition. And you've got to think about things like menu selections are often chosen the day before, and let's face it, who really wants to think, apart from somebody who might be particularly interested, actually is choosing something this morning, going to have, what I want to eat tomorrow. People really should be choosing what they want before, when the meal's coming. It's difficult to make that happen, but some environments do. So I'd like you to have a look at that as well when you get into practice about how they can how do we help patients' choice and presenting it on a plate. There have been times that I have seen in my healthcare practice and when I've been in clinical environments, people have been ordered sandwiches and they've stuck them on the patient's table and they haven't even offered to unwrap them and put them on a plate, or checking whether the person can actually dexterously eat them, and therefore people won't say anything and they get left on the side. Keeping a record of the food, looking at portions, offering snacks between meals, quite difficult. Nutritional supplements is quite a difficult thing. Protected meal times. I was talking to students the other day about research that's taken place into protected meal times, and you will see this in clinical environments, that they actually say that people don't visit, that doctors don't come, and that people don't get taken away for tests during meal times, so that people can be there to eat their food. And there's research around people prefer to be able to eat undisturbed. If you have visitors, it's not polite to eat while somebody's there. Also, one of the care environments I worked in on a ward where stroke patients were cared for, when they were asked of what their preferences were, they were embarrassed about eating with some degree of paralysis in their hands or their mouths, and making a mess when they were eating, and how embarrassing it is for people to see that, like their visitors. So all sorts of stuff like that. So there's a tree trace system where you can identify certain coloured trays for people that need help or assistance, and there should be people available to. Oh, you haven't had to taste it today, so we're going to have. I'm going to move that on to obesity. So, are 50% of adults overweight in England? We've talked about that already. The things with obesity is it causes high blood pressure, it can cause infertility, predisposes diabetes, causes problems and stress on the cardiovascular system, and it also causes depression in terms of sense of well-being and worth and personal body image. And the other thing is it can cause sleep apnea, where thickening around the neck area when you lay down can actually cause pressure on and collapse the larynx, and people will actually obstruct their breathing and while they're sleeping. And which means when your carbon dioxide level gets so low, you wake up. So these people don't sleep properly, which causes all sorts of problems in their life in terms of being tired all the time, etc., etc. Something it's quite interesting to look at. So we know all about this huge problem in health, and all of us are pretty aware about trends in obesity. So it's about assessing people. Waist circumference distribution of body fat is being considered now to be a better indicator than BMI. So that's an interesting point. And here we go. Exactly what you pointed out earlier, that if their BMI is high, it doesn't actually help. So NICE have obesity clinical guideline number 43. Please do have a look. So again, the waist circumference measurements and the chart that goes with that. And childhood obesity is on the rise. We've already talked about that. I want to now have a look at what you've been saying. Can clinical obese be classified as being malnourished? Yes. How do you spot the signs in patients eating if they're living in the community? Very true. It's all very well GPs doing that, but if somebody's being cared for in the community and you go out the community nurses, you'll find that there will be nutrition assessments done, and if they are at risk, then plans to be put into action to review what they're eating. Obviously, in their care homes, it's easier to do that, and it may necessitate people visiting regularly to assist with eating. Do people in care homes and hospitals have freedom of choice about what they eat or don't eat? Well, the answer to that is, to some extent, I agree. Hospitals have some interesting policies around whether people can't think of the words, whether people can eat food that's been brought in for them or not. I've worked in the area of respiratory care, and we have people with cystic fibrosis who have to eat little and often and have to eat high protein foods, and trying to get some of the things like high protein drinks and nutrition, palatable, appealing meals has been quite difficult, and therefore we have arrangements where food's brought in for people. And if it's the only way to get people to eat something appetizing is to have food that's been prepared, brought in, the risks is that things like salmonella from things being sat on the side, and storage of food and E. coli because it's been brought in. Because, as you know, in our hospital environments, we have to we ensure we adhere to strict codes of food preparation and hygiene. So you may find that people are asked to sign disclaimers, or families saying that they're taking responsibility for food that's been brought in if somebody falls ill. Care home's a little bit more tricky, isn't it? Yeah, Jennifer's saying that people are asleep and meals are put in front of them, and then it's too cold and they don't want to eat it. It's a tricky one about meal times, isn't it? And in an ideal world, and looking at nice recommendations, if you look at them, there should be somewhere where food can be obtained out of normal routine hours. So again, go and see if that happens. Is there something, a provision for people that can have food provided for them if it's not the normal set routine meal times? I'd really be interested to see if you find that. So what about your health promotion role in terms of people that have weight issues like obesity, but actually that's not why they're in hospital, or in connection with community care? Well, as you know, every nurse has to promote health, and that's a really good question. And your role in health promotion, and healthcare professionals are easily placed to provide health promotion. And how do you do it? Well, please think about it and get some advice, but there will be some guidelines and some thoughts around how we promote health with people in general as part of their general well-being. GP practices are being challenged with this, and you may find yourself that you may find that people are giving you information leaflets or guidance if you're going in for routine GP appointments. We're supposed to, as healthcare professionals, take every opportunity to provide health promotion, and so that it's second nature for us. We don't do this as well as we could do, and certainly we're going to be focusing on how our role as health and health promotion needs to move forward, and watch this space. It'd be quite interesting. Right, a couple of people are really shocked when I said it costs 58p per day for meals. So go and see what sort of food that they're actually providing for 58p. You'll be pretty impressed, actually, but also maybe dismayed. So I'd be really interested to see when you go on your taster days. Ooh. Charlotte's saying that she did some voluntary work in hospital and do a patient survey, and surprised that they were saying that they were pleased with their meals and liked the food given. So there you go. Interesting one. Hospitals do try really hard to look at this. It's now a requirement that they do provide the food. Yeah, some people don't want healthy food. They want to eat chips. So our role in health promotion is to talk about, well, actually, you might need to have these extra nutrients, etc., etc. Pollyanna has talked about how people get a whole range of options, vegetarian options, and every effort to make people to cater for individual needs. This is the gold standard. This is what we want to see. So again, we'd be really interested in you feeding back what you've observed about this on your taster days. Yeah, you need to think about on the walls what happens on the walls in terms of who offers assistance for people for eating, and who could do that, and should people be, there's this question, should people be employed specifically to assist people with eating their meals? Quite interesting one there. Yeah, Louise is asking if people are encouraged to bring in drinks, fruit and things to help eating plans. Yes, we should do, but I'd be again interested to see whether you observe that. And why not? Why not? Somebody else asking, is it easy to cater for patients' religious requirements, e.g. halal? Very true, and that would be a really interesting question for you to ask. And the last people I looked after, the family did bring in food for that patient to eat, but they were in for a short period of time, and their ability to eat and drink wasn't compromised by the reason why they were unwell. Yeah, there are high-calorie milkshakes available in the clinical environment, and here's a word for you. Patients need these prescribed, and they're prescribed. They're called supplements, but what happens is you encourage the patients to drink those supplements, but because they're drinking those, they then stop eating food because they're feeling full and they're getting their requirements from the supplements. And so you need to think about how you get them back into eating a nutritious diet rather than relying wholly on supplements. So it's an interesting thing that happens there with supplements. Prescribed 3 times a day, and you see that for the whole state. They should be tailed off and tailored so that people return to normal eating habits, and rather than replacing their nutritional intake with supplements. Yeah. What if nurses are overweight and malnourished, and you've got to give health promotion? Interesting one, isn't it? Should we take students onto a course who are obese and overweight? Wayne's asking about difference between adult and paediatric meal choices with meal appeal. Yeah, I mean, be interesting again in children's environments what they do in terms of offering food and how they present food for children's consumption in children's areas. They do it differently. Yeah, Rachel's come up saying that some areas that she knows where they use volunteers to help with feeding, and of course family. You can help, use family to help with feeding. They obviously need some training around, how to spoon food into people's mouths and things like that. With not taking, and again, the whole thing we talked about with promoting self-care and self-esteem by not, assisting people to eat rather than feeding people. You've got to get the balance right. So the other thing, yeah, should nurses lead by example? You're right, Jay. It has been the topic of tweet chats that have gone on over the past few weeks, and certainly over the past year or so, is about what nurses should be doing and leading by example. Yeah, looking skinnier doesn't necessarily mean healthy. Thank you, Susan. You're right. And so, yeah. The other thing I wanted to add is to this discussion this morning, because we still have just a few more minutes left, is and we talked about sending out for food or relatives bringing food in, and the students and I debated this last year, and I think it's an interesting point that a lot of hospitals allow external companies to sell what's considered as unhealthy food in hospitals. So I know from our discussion last year that Griggs have a pie and pasty shop in hospitals. I know at RD&E they also have things like places that people can go to buy what's considered as unhealthy. And to add to this, I also know at Great Ormond Street there is a McDonald's in the hospital premises. I don't know what your thoughts are on that in terms of the things that we've been talking about on health promotion. So patients can access things like burgers, pies, chips. Yeah. Emily says some people might like a treat to see them through the day. Oh, Louise has just seen an article saying that champagne every day could prevent dementia. You'll find that any alcohol can prevent something in someone's opinion. Yeah, Subway, Dominic's, Derriford as well. Is that right? Is that a good thing? Wayne said he's getting hungry, so I'm making him feel hungry. Yeah, good comment. Yeah, KFC in hospitals. There's a difference between it possibly being good to stimulate an opportunity for people to eat what they want, but in this nation of obesity and responsibility and companies' responsibility in promoting healthy diet, is it appropriate for these places to be in hospitals? Because at the end of the day, the reason they're there is for them to make loads of money, not for the state of your health. Yeah, some of you think it's great to pop into the takeaways and fast food places. Yeah, no, it doesn't. Well, it does make. Yeah, it does. Dominic's saying, does it make money for the NHS with franchising? Yeah, obviously the hospital gets a financial kickback from the companies from allowing them to set up in their buildings. So yeah, interesting point. Yeah, is it better? Is it good that they eat food that's better that they like rather than eat nothing at all? So that, as with always everything, there's a balance. And I guess I finish on a note. I worked in a clinical area where we had people that came in for short tests, overnight stays, and we had a patient in for that requires 3 days fasting, and we're looking at hormone imbalance, and they actually can drink clear water for 3 days, but they can't eat anything, and we take blood tests from that person over the period of the day to look at peaks and troughs in glucose, insulin, and other hormones as well. And we used to have people in for 3 days, and they starve for 3 days, which isn't very nice, and it's quite a long period of time to go without food and all that. So what we always used to say to them is, whenever the time of their fasting finished, we'll get something in for you to eat. So if it's like, it's 6 o'clock in the morning, we make sure that they get their breakfast, or if it's like 3 o'clock in the afternoon, we make sure that there's food available. But what I always used to do, and that's me being the ward manager at that point as well, is saying, or if there's anything you would like your family to bring in for you, because you haven't eaten for 3 days. And so we have this negotiation when we do their assessment, and when they first come into hospital. And so, as always, they usually say yes, that's great, thanks very much. And so I came into work one morning, and the night staff said, did you tell Mr. So-and-so he could have a takeaway at the end of his 3-day fast? I said, well, he could have whatever he wanted. He said, yeah, he ordered a takeaway, a pizza takeaway, but he also made ensured that the rest of the patients in the ward had the opportunity to have the takeaway in as well. So apparently there was a lot of takeaway pizzas in the ward that night, and that's patient's choice for you. A quite interesting one. And the staff apparently were also asked if they wanted some too. So yeah, sometimes it's good. Sometimes your agreements with patients have a little bit of a ripple effect. Okay, it's 10:40, and I've more or less had my say. Some people have come up with an extra couple of things. It's again about missing meal times and how things should be improved. It's insurance. So these are things for you to look out for. What happens if people miss meals? What provision is available for them? What is the state of the food like for and choice? Some of you have experience and shared your experiences with us this morning already. That's really interesting, and that's quite good too. And thank you for that. So what I'm going to do now is I'm going to move on to the next slide and look at what's important, what causes malnutrition are, things about the screening, and looking at nutritional status, thinking about obesity and our role in the health of the nation, which is a biggie. And obviously here's your references and further reading, and there's plenty around, as it's, as always, a very hot topic. Right, so if you just bear with me just a ticky, and I will talk to when we're starting again. Okay, going to start again at 12:30, giving you some time there, where we're going to talk about fluid balance. I'm going to stop recording at this point.